All right, welcome to week one of Clinical Management Fitness Athlete Essential Foundations. Let's dig into what we're all here to learn a little bit more about, which is loading, how to better understand loading, what is actually going on when we load patients, what's going on physically, biochemically, the evidence supporting loading of patients, especially getting heavy, what training volume looks like in the aspect of not only the general population, but this athletic population, this fitness athlete population, how to dose that load out in the clinic when you're giving out your therapeutic exercise and corrective exercise, and the importance of integrating intensity into the clinic in your TheraX. So let's get into what is load. This is the basis of our profession. We're known as the exercise people. Other providers know that that's what we do. People who've had physical therapy in the past know that we're going to get them exercising. Maybe they don't know why, and maybe we don't know why, but we are the exercise people. That's great because exercise is showing up in the literature is the most effective intervention for long-term reduction in symptoms, reduction in future injuries, recovery from current injuries, and also the reversal and prevention of preventable disease, not only chronic diseases, high blood pressure, diabetes, that sort of thing, but we're learning more and more that you become even more resilient to things like the flu, the better in shape and the stronger that you are. Now, unfortunately, this is an area where PTs are not strong at all. Some PTs come into school with no background in this. Maybe you're one of those folks who studied piano in undergrad and then came into PT school. And most of us in PT school can agree we kind of had a lackluster experience with learning exercise, learning load, learning how to do it. We were all kind of told in school that we should be doing it, but there was no further guidance, and your clinical experiences in school probably determined how much you did or did not learn about loading. Now, with loading, what's really going on here? What's going on is we're at homeostasis. I'm sitting here in my chair at rest. We're going to give that patient, that client, that athlete some sort of stimulus, some sort of load. We're basically going to make them exercise, and that's going to cause an adaptation in their system. It's going to cause a change in their functional activity, and this comes with a multi-dimensional application. We can induce a stimulus with intensity, with an increase in volume, or with manipulating rest intervals, or even combining some of those together to get some sort of stimulus into the body, and we'll dig a little bit deeper into that on the back end of the session. Now, for you visual learners, this is kind of what it looks like. This is kind of the effect of exercise over time on the body. We have, sitting here, baseline, this purple line, homeostasis. We have some sort of load, some sort of stimulus that's going to affect and disturb our homeostasis. We're going to need to recover from that, and as the body recovers, we enter this period of supercompensation. This is when our muscles get stronger. This is when our muscles start to get a little bit bigger. This is where we maybe start to get a little bit faster, and certainly where we start to see things like cardiorespiratory changes, increases in mitochondrial density, all the wonderful changes that happen with exercise. We have some sort of optimal rest time here between exercise. Now, we do know we need to be exercising almost every day, and so here that is really just recovery time for different muscle groups, and we know that we can work other muscle groups here while the currently fatigued muscle groups are recovering, and that's how we can kind of keep this supercompensation effect rolling basically all week long, every week, most weeks of the year. Now, what's happening here when we're loading? We are inducing a concept known as mechanotransduction. We are physically applying force to cells. Cells are changing at the cellular level, and that's what causes all the changes that we see with exercise. So individual cells can respond and sense to physical load. That's called mechanocoupling. We know that cells can communicate that response to nearby cells, even cells that didn't actually get the force physically applied to them, through a process called cell-to-cell communication. And then neighboring cells will actually respond and remodel their cellular matrix, even if they didn't have the load physically applied to them. So we cause a more global change with exercise beyond just the individual cells that have the force applied to them. Now, over time, we get some really cool things going on with mechanotransduction. This is a great case study. Dr. Stuart Houston transposing a fibula into a tibia in a child that did not have a tibia. And over time, the loading on that bone, the mechanotransduction to those bone cells, turned the fibula into a tibia. And so we take this and look at this and think, well, yeah, of course that would happen. We need to load bone to grow it. That's a no-duh, right? But we don't often think of this concept the same way when we think about loading tendons, loading muscle. It's all really the same, and we need to get comfortable that we need to actually load that tissue to cause changes like this in the body. We know that there's a biochemical response with mechanotransduction. We know that basically all types of tissue remodel to load, bone, muscle, tendon, what have you. We know that things like cartilage are often underloaded. Folks with osteoarthritis are often told not to exercise to maintain whatever they have left. And we know we need to kind of throw out the concept of wear and tear and understand the concept of wear and repair. The mechanical loading can cause cartilage to regrow through a number of different processes, both by inhibiting current inflammation and then facilitating an increase in anti-inflammatory as well as structures around the joint like the synovial capsule, joint synovial fluid, and then also just promote anabolic chemicals in general that's going to promote cartilage growth. As well as mechanical transduction and mechanical loading can facilitate pain reduction through a combination of anti-catabolic and pro-anabolic effects. So not only is loading helping our current symptoms, it's helping pull some inflammation away, it's also inducing a pro-anabolic effect that's going to make that tissue stronger and more resilient to future injury as well, which is cool. A really cool double dipping effect there. So what is the evidence for using load, for using exercise to treat symptoms in the clinic? It's very, very strong, and stronger evidence is coming out every year. So I love this study looking at physical therapy versus injections for OA of the knee, looking at 156 patients here, all a little bit older, all with a mean age of about 56. All these patients had diagnosed osteoarthritis in one or both knees, and they were randomly assigned to receive an injection or physical therapy. In those that received physical therapy, their pain was reduced, their WOMAC scales were altered, they had an improvement in their alternate step test time, their timed up and go, and their global rating of change. Those were all better at the 1 year mark compared to injection. And so more and more studies like this are coming out comparing interventions like injections and surgery and medicine to physical therapy to basically just general exercise and seeing these improvements. Let's talk about some more. So looking at how do we manage tendinopathy? So getting away from bone and cartilage and looking at tendons. What's the current clinical management for the conservative management of Achilles tendinopathy? We see that the treatment with the highest level of evidence for treating Achilles tendinopathy is exercise. Promoting mechanical load to promote remodeling, decrease pain, and of course improve function, calf muscle endurance, strength, and lower leg function. So getting load into that tissue, whether it be bone, tendon, cartilage, etc., is the way to go when we look at the evidence. Now, what does the evidence say we should be doing when we look at this article from European Spine Journal? I love this study. Clinical Practice Guidelines for the Management of Non-Specific Low Back Pain in Primary Care. So these are physician clinical practice guidelines. These are CPGs for physicians. What do they say? All of these guidelines recommended against the use of imaging for nonspecific low back pain. 11 of the guidelines recommended spinal manipulation, so cracking somebody's back. And all of the clinical practice guidelines recommended exercise. So stop taking pictures of people's pain, especially when it's not traumatic in origin. Use manual therapy, use tools like spinal manipulation to calm down pain, and then what? Get them exercising. I love this article to reference, especially to those physicians who may come back at you and ask why Nancy came in for her follow-up after 4 weeks of PT and told the doctor that you were having her deadlift and kettlebell swing and use the rowing machine. When they come back and say, why are my patients exercising? Why aren't you doing ultrasound and diathermy and hot packs? You can say, Doc, look, Have you seen this? This is from 2018. This is actually an article meant for you, right? These are physician practice guidelines. Have you checked this out? I'm doing exactly what the physician evidence says I should be doing. So I love to have this article on hand to have that conversation. Now we get into beyond just loading and the effects of loading. What do we see health-wise, long-term health-wise, and things beyond just physical health? What about mental health? We look at the long-term effects of exercise on depression. So long-distance ski racing. What did we find? We looked at a huge sample size, 395,369 skiers. We studied them across 21 years. We found that the risk of developing depression was significantly lower in skiers versus non-skiers, actually a 47% lower risk, which is huge. And we also found this cool finding. The highest fitness levels measured by those who finished the races the fastest was associated with the lowest incidences of depression. So the people who were in the most shape were the least likely to have mental health issues, depression in this study, which is really cool. So going beyond just reducing pain and improving strength, what does exercise do for the human as a whole? There's some really cool stuff coming out of the mental health research. Looking at chronic disease, we're overwhelmed with chronic disease. The majority of patients we treat need a lifestyle intervention more than anything else in their life. So what's the impact of a little dose of intensity, a little dose of cardiovascular load on the body? Quite incredible. This study looking at 34 folks, all older adults here, all 65 plus, put them in two different groups, receiving the treatment 1 time a week or 2 times a week compared to control. The treatment, very, very minimal here. 10 rounds, stick with me, 10 rounds of a 6-second sprint with some recovery. Enough recovery to get their heart rate back down. 60 seconds of exercise once or twice a week compared to control. Massive influence on these folks. Both sprint groups had a significant reduction in resting blood glucose, improvements in 5-time sit-to-stand, tug, and submaximal treadmill tests to estimate their VO2 max. So what does that show us? It shows us the benefit of even a small dose of exercise in a population that's not currently exercising. Again, going beyond just reduction in symptoms, improvement in strength, what is the effect on reversing chronic disease? Now, unfortunately, we get here. So that's the evidence to use exercise to get people loading, to get their heart rate up. What is actually happening out in practice? What is the usual care for low back pain? This study looking at treatment from family practice physicians, so when folks go to see their primary care doc, and then treatment coming out of emergency departments. Looking at 26 studies, about 195,000 patients, finding that less than 20% of patients received evidence-based information from their physician. So all the stuff we just talked about 1 in 5 or less got told that they need to be exercising, that it's going to help their pain, it's going to improve their function, it's going to help reverse their chronic disease. Specifically for low back pain, 25 to 33% received immediate referral for imaging. Hey doc, my back hurts. Great, go get an MRI, here you go. 30 to 60% received immediate prescription of opioids. Hey doc, my back hurts. Great, go get this MRI. By the way, here's some Percocet. I hope that helps. Conclusion here quite strong. Usual care includes the overuse of imaging and opioid prescriptions. Suboptimal care contributes to the massive burden of this condition worldwide. So quite profound in what we know works and what's actually being delivered on the ground to our patients. And we have to get to this point. We have to get to the point where we recognize that strong people are harder to kill than weak people, and Mark Rippetoe would argue more useful in general. And this comes from the aspect of knowing everything we just talked about, that loading is going to make your tissues stronger. Mechanotransduction is going to make your bones, your muscles, your tendons, your cartilage stronger, more resilient to injury. Regular loading, regular exercise is going to improve your cardiorespiratory system. It's going to help reverse any chronic diseases you may have and prevent the future onset of them, right? Somebody that's exercising 6 days a week at high intensity is very unlikely. It's statistically impossible to develop something like type 2 diabetes. So we need to recognize that this applies to our patients, and we need to be using our time in the clinic with these patients not only to help their symptoms, but make them a little bit more resilient to injury, knowing that the stronger we can get them, the more healthy we can get them, the better off they'll be as a person down the road. So how do we do that? How do we start to accumulate volume? What does exercise look like? How much should people be exercising? Let's talk about that. We know there are some baseline volumes we need to understand. There's a concept called minimum effective volume. That's the lowest volume that can be performed to still receive some sort of improvement. Now, we don't know where that is for everybody, but that's maybe 1 to 2 days a week of exercise. You're not going to get much healthier, you're not going to get much stronger, but yes, it's better than sitting on the couch. The opposite end of that continuum is maximal recoverable volume. That's the highest volume that can be performed while still able to recover from that exercise. So think of training for an event like a marathon. In this fitness athlete population, think about training for a CrossFit competition, maybe the CrossFit Games, an Olympic weightlifting meet or a powerlifting meet. We're training to peak and perform at a competitive level event, a maximum recoverable volume event that we can still recover from, right? After you run a marathon, you feel terrible for a couple days, maybe even a week or so, right? It's a lot of volume on the body. You are physically and even mentally tired, but over time you will recover, you'll feel like running again, and you'll kind of jump back into that cycle where you restart training. With lifting, we know we train to peak at a competition. We are increasing reps and sets and weights to peak for our event, whether that's powerlifting, Olympic weightlifting, CrossFit Games, whatever. And then after that competition, we know we need some time off, a couple days off, slowly get back in the gym and recover from that volume. But we can recover. Going out and doing a CrossFit competition is very tough on the body, but it's not like you'll never be able to exercise again after doing that. In the middle of those two volumes is the maximal adaptive volume. This is the training volume that yields the greatest adaptation. This is the most effective volume to exercise at. Appreciate that you cannot train maximal recoverable volume every day. The best way to train for a marathon is not to wake up every day and run a marathon. Some people do that and it breaks down their body pretty significantly, but that's not the most efficient way to do that. The most efficient way is to slowly increase your load, increase your training until you're almost to marathon level, run the marathon, take a break, deload, do some really slow, low volume loads, and kind of get back into that cycle. And that's maximal adaptive volume. That's training every day, 4 to 6 days per week at a volume that you can recover from more easily, that's not as kind of destructive on your body is maximal recoverable volume. So we need to get folks training at maximal adaptive volume on a more regular basis. We call this the Goldilocks zone. So if the minimum effective dose is on the far end of maybe undertraining, the maximum recoverable volume is on the upper limit of overtraining. We can't train there every day and have success. We need to find that maximum adaptive volume, that Goldilocks zone, and get folks kind of overreaching a little bit into recoverable volume, but mainly hanging out here in the MAV level. Over time, we know that MAV changes. We know that our adaptive potential with exercise is huge when we first start. Anybody that's ever started lifting weights was amazed when every time they came into the gym, they could put 10 more pounds on whatever lift they did. Over time, that quickly decreases, right? We call those beginner gains. That adaptive potential shrinks over time. The longer you've been doing something, the MAV window kind of shrinks, and other factors become very, very important here to continue to adapt. Nutrition becomes a big key. Sleep, other forms of recovery become very important to make sure that our adaptive potential window stays as large as possible and that we continue to get stronger. We continue to progress our cardiorespiratory fitness. We continue to get faster with our runs, that sort of thing. We also need to understand that with our masters athletes, with our older adults who are training into who knows the age range, that we'll talk more about this in week 7, but we know that MEV and MRV relationship switch, that the minimum effective volume might be more than we can recover from. And what does that mean? That means that maybe that 78-year-old that has been doing CrossFit since it started, since 2000, when they were in their early 50s, could come to the gym and train 4, 5, 6 days a week and recover from it. Maybe now, 15 years later, at the age of 68, the age of 70, maybe that athlete can only recover a couple days a week of training. So maybe that person is only in the gym 2 to 3 days a week. How do we know when that person has reached this point? We talk to them. They start to complain of just feeling like they can't recover, of being very uncomfortably sore, of feeling like they maybe need 1 or 2 days off after every time they work out. And that's okay. We need to understand that adaptive potential is not gone, but it's certainly shrunk a lot, and that the relationship between the minimum effective volume and the maximum recoverable volume have switched. The minimum dose there could be more than that person could recover from. Now, we know that the longer people have trained, the less concern this is. We can certainly look at the masters athlete divisions in powerlifting, weightlifting, marathon running, CrossFit Games, and see folks in their 60s, their 70s, even their 80s continue to get faster and continue to train hard. So we know for folks that have been exercising a long time, they've kind of built up that resilience and their body is very efficient at recovering, and we're less concerned about this, but know that that relationship is out there. Now, how do we find this? Oh no, my picture's way down on the page. All right, we fixed it. So finding maximum adaptive volume, we need to understand a concept called the acute to chronic workload ratio, pioneered by Tim Gabbett and colleagues. And this is comparing the previous 7 days of workload, acute, to the average of the previous 28 days of workload. That's the chronic workload, acute to chronic. Now, this applies to physical activity in general, exercise, running, weightlifting, whatever. This also applies to folks who have a very physically demanding job. Think of that line worker, that person lifting stuff overhead at work, that person out working on the poles, a utility worker. We can certainly look at this concept with those workers as well. Maybe you call those your industrial athletes. I like that term. We need to help these folks find the sweet spot where we have a decreased likelihood of degenerative changes due to undertraining. Maybe that's that MEV. And also avoid the likelihood of injury due to overtraining. That's that that MRV, which would be over here in this danger zone. So we need to help folks find this sweet spot of training where they're working out enough that they're not at a risk for underuse, for undertraining, but they're not at a risk for overtraining. So the difference between MEV and MRV, and getting them in the middle, training at MAV. Now, what does that look like? That looks like something like this. These are the newer physical activity guidelines for Americans from the Centers for Disease Control. And so they've been basically doubled since the last time they issued these guidelines, and basically titling their guidelines Move More, Sit Less. So now saying we need 150 to 300 minutes of moderate intensity aerobic exercise over 50% of your heart rate max per week. So up to 5 hours, or 75 to 150 minutes of high intensity aerobic exercise greater than 70% of your heart rate max. Plus, you need at least 5 hours of moderate physical activity throughout the week. This could be your job at work. This could be lifting stuff overhead at the factory. This could be raking your leaves for 6 hours, mowing your lawn, playing with your kids, any other recreational activity that's not specifically exercise. And oh, by the way, you need to be doing at least 2 days of resistance training at or above 60% of your 1 rep max for those muscle groups. So all these numbers doubled since the last time they issued these, saying that Americans just don't move enough, and that's why we have all the physical health issues and some mental health issues going on that we do have going on in this country. Now, looking specifically at the CrossFit population, trying to find that sweet spot for training volume, we look at the injury data from this great systematic review and meta-analysis, finding that injury is most likely in those training CrossFit less than 3 days a week. So these are your fair weather fans. These are the folks that cherry pick the workout. Maybe you're this person. You look at the workout ahead of time and you think, strict pull-ups and running, not today, gonna skip that one. And then you look at a workout that's max out power clean and you happen to have time in your schedule for that workout. We know who you are. That's these folks. They're training CrossFit, yes, but not enough. They are not getting exposed to enough movements to train enough of their body, and they're at a higher risk for injury because they are undertraining. Likewise, injury is most likely in those training CrossFit more than 6 days per week. These are folks who are overtraining, right? More than 6 days a week is 7 days a week, right? That is training with no rest day. And we have a conclusion here that CrossFit practice is associated with a higher level sense of community satisfaction and motivation than other exercise programs. So if we can get people in the gym, if we can get them training CrossFit 4 to 6 days per week, finding that sweet spot where they can have that recovery going on and kind of ride that super compensation wave again and again and again, and they seem to like it, then we've helped them find that sweet spot as far as volume goes. Now, how can we tolerate spikes in volume? If we have increases, if we're trying to train for competition, if we're an industrial athlete, maybe we have to work overtime around the holidays or something, we have a spike in workload. What are the characteristics that will let us tolerate those spikes better? Looking at this study again by Malone, Gavin, and colleagues, a study of 40 folks here. These are hurlers. And looking at the relationship between workload, here they calculated workload just by multiplying the duration of exercise by the session RPE. Looking at the injuries that occurred, and then looking at the physical qualities of those in the study, and finding that a moderate weekly workload combined with a stronger 3-rep max trap bar deadlift was found to be the quality that was the most protective against injury. So the athletes best able to tolerate spikes in volume were those that were the strongest. And again, there's that evidence for strength training, even for folks who may not consider strength training. Your runners, your cyclists, folks who are only concerned with getting faster in their cardio. This is a great study to show them, like, hey, you're going to tolerate increases as you train for that marathon, as you train for that century ride. You're going to tolerate that a lot better. Your joints, your tendons are going to feel a lot better if we can get you stronger. If we can get you squatting and deadlifting and loading up your legs, your joints are going to feel better. You're not going to have any smoky knee pain. You're not going to have any hot tendons if we can get some strength training dosed in alongside your cardio training. I love this study. Looking at what kind of shows up as the king of injury risk reduction, it's showing up more and more and more to be strength. So looking at this study, barbell squat relative strength is an identifier for lower extremity injury. So 71 folks, these are all college athletes, men and women, from a variety of different sports, football, baseball, volleyball, looking at their 1-rep max back squats and comparing it to their injuries, and finding that back squat strength is significantly lower in athletes who experience an injury. And what's the cutoff here? Back squat strength below 2.2 kilograms per kilogram of body weight for men and 1.6 kilograms per kilogram of body weight for women is a risk factor for lower extremity injury. What does that translate to? That translates to about a body weight back squat for a male and about a 75% body weight back squat for a female. And so if you've trained powerlifting, if you've trained Olympic weightlifting, if you've trained CrossFit, any amount of time, you know that this is a very achievable goal. This is a goal that's usually achieved 6 to 12 months, maybe 2 years on the top end of regular exercise, 4 to 6 days a week. This isn't a far-reaching goal by any means to hit a bodyweight back squat for a man or a 75% bodyweight back squat for a female. Now, if you look at your athletes, especially maybe your high school athletes, even your middle school athletes, they are probably not doing any sort of strength training. They're nowhere close to this. Even some of your college athletes are nowhere close to this. Even folks who are going to the Globo gym, training in their garage, yes, maybe they look muscular, but when we actually dig deep into their strength, we find they're not hitting this mark. And looking at this research tells us it's probably pretty important, and that we can probably also correlate this and say the same could probably be said for the deadlift in the back. If you're not able to deadlift your body weight or 3/4 of your body weight, you're probably more likely to experience a back injury. And I bet if we looked at this research with overhead lifting and pressing, we'd find the same thing in the shoulder as well. So understanding that strength is a big factor in how likely we are to be injured. How do we monitor load? We're on board with loading. We want to get load into people's systems. How do we monitor it and find out that we're loading people appropriately? We can use a bunch of different systems. The first is RPE. So before we dig too deep, it's important to know, asking people, yes, there's a lot of objective ways to measure load out there now. Asking people is a very reliable way to find out if they're training as hard as we think they are and trying to get an idea of where they're at load-wise. This is a great study from 2018 looking at the relationship between session RPE and training stress score, which is a way that cyclists monitor training intensity, and finding this beautiful correlation, 0.97 R value. Look at that correlation. Asking people, hey, how hard was that? It was pretty hard. Well, that makes sense considering you were training pretty intensely. Hey, how hard was that? That was super easy. Well, that makes sense considering you were basically not working out at all. And just finding this wonderful correlation of asking people RPE in the moment with an individual lift or at the end of the session. Now, what's the evidence say about the validity of RPE? Some really good research here comparing session RPE to training intensity. Here, the other variable was heart rate and seeing which one was more accurate. And seeing the correlation of session RPE to training intensity was not as good as heart rate, an R value of 0.68, but very close, an R value of 0.53. And it shows us the practical application of asking for session RPE versus needing to monitor heart rate during training with our athletes. Another study here looking at guiding intensity-based training on RPE versus pre-programmed guidelines, and finding that those who self-guided their intensity based on their current RPE, this feels like a 7 out of 10, regardless of where I'm supposed to be at based on my programming, did hit higher intensities less often, but had very similar results in muscular strength and hypertrophy gains. There's also a system called reps in reserve, or autoregulation as it's known in the literature. This is less commonly known, but this is a system that's out there. It's being used. Olympic weightlifters, powerlifters are very comfortable with using this system. It's often how they receive their programming from their coach. So when we look in the strength and conditioning literature, it's called autoregulation. It's a system of correlating repetitions left in the tank to RPE. So an RPE of 7 out of 10 would be 3 reps left in reserve. How do we ask people? We simply ask them, how many more do you think you could have done? Okay, it's supposed to be 4 by 8. You did a set of 8. How many do you have left in the tank? How many do you have left in reserve? I could have done 4 more reps. Okay, if the RPE was supposed to be 8, then that's too easy, because at an RPE of 8, you should have only felt like you had 2 reps left in the tank. So this is a way to guide loading to make sure that we're lifting heavy enough. We know that it correlates very well to objective intensity measures, including heart rate. And again, it's commonly used in strength training programs, especially for powerlifters and Olympic weightlifters. It will say every 2 minutes, do 3 power snatch. And I want this to be a reps in reserve of 3, which means an RPE of 7 out of 10. Now, the research is very good here as well. When we look at estimating repetitions to failure with reps in reserve, we see that during resistance training, subjects are able to accurately estimate how close to failure they are using reps in reserve. These subjects were asked to estimate their reps in reserve during training, but then also complete the lift to failure, and we found an error range within about 1 rep for bench press and leg press. So again, much like RPE, when we ask folks how many reps are left in the tank, they're very accurately able to estimate and tell us how heavy the lifting is. When we look at the relationship between velocity loss and reps in reserve, we see that there is a very great correlation here, and that we're able to accurately predict how close to failure we are comparing bar speed to reps in reserve. So as we measure bar speed on a bench press or a back squat, as that velocity slows down, we know that person is closer to their max, we know they're closer to failure, and when we ask them reps in reserve, they're able to accurately match that up to the velocity loss, which is quite cool. And we know that folks training this way see greater improvements in strength training, much like RPE, than a fixed loading program. So when we look at repetitions in reserve versus a fixed load based on a theoretical or known 1 rep max, both groups do get improvements, but the repetitions in reserve group see greater improvements in strength rather than fixed load. Now, we can speculate on why that is. Maybe the group being told to train at 90% and always train there, even if it doesn't feel good, maybe we could argue that group is overtraining. Maybe that group is under-recovering. They're not getting as much of a super compensation effect as the group using reps in reserve and going by feel is maybe able to get in the gym more. They're not feeling as beat up, and that leads to greater improvements over time. We don't have that research yet to dig deeper into questions of actually why this is better, but we do know that it's showing to be better to use repetitions in reserve or RPE compared to fixed loading. This cool chart for you, just putting it all in one chart so that you can print it out, have it in the clinic, especially if you're not familiar with it, having RPE and reps in reserve on the same scale. So like we talked about, if we want somebody to be training at a 7 out of 10, they should only have 3 repetitions left in reserve. And if they finish a set and say, I could have done at least 6 more, we know they're at a 6 out of 10 or less and that we need to increase the load. Now, when to use which system and with who? Practically, I'll tell you to use whatever system the person appears to understand best. Some folks have never used RPE. Some folks have never used repetition in reserve. If they're comfortable using one system and you ask them that, use whatever system they're already comfortable using. RPE is generally understood better by adults. Repetitions in reserve is better understood with younger kids, teen athletes. I find when I coach our teens, they understand reps in reserve way better than RPE. If I ask them to rate a lift 0 to 10 on the RPE scale, they just kind of stare at me and their eyes cross a little bit. If I ask them, how many more do you think you could have done? And they say 3, 4, 5, that lets me know that repetitions in reserve is better understood with that population. So ask if they have familiarity. If they do, use whatever they're already using. Some of them are already probably using one or the other if they're coming to you as an athlete that's already doing programming somewhere. And don't be afraid to switch gears if they're not understanding the current system you're trying to use. If they seem to not be understanding reps in reserve, try RPE and go back and forth and find the one that they best understand. Now, the thing we can use is an AMRAP set, which we haven't talked about, which we'll get to better understand getting dosing loading in. But before we talk about that, we need to understand that arbitrary loading is out. Just giving people 3 sets of 10 is not cutting it. The literature supports that PTs in general underdose patients, and it's probably the main cause of re-injury, especially in surgical folks, and that it's costing a lot of money to the healthcare system. And that's not a way we want the research to shake out, right? We already have trouble getting paid as it is by insurance companies, even our patients. They don't see the value in PT. We have to make sure we reverse that trend in the literature that says PT is effective. It's the most effective thing you can do. We need to make sure that we're pushing patients, clients, athletes to be lifting at 60% of their 1 rep max or above in order to truly facilitate strength gains and remodel that tissue. So 3x10 with the yellow TheraBand is not cutting it. It might be enough at the beginning, especially post-op, but it's not enough 3 times a week for 12 weeks. That's a stimulus that the body can very easily adapt to. It's not objective enough. It's not hard enough. We need to understand that using reps in reserve or RPE has been shown to be superior to fixed loading. And it's also how we can get our dosing dialed in the clinic, especially with this population that you came to this course to learn more about, the fitness athlete. It's how they train anyways. They know their maxes. They know what 70% of their max. They know what 90% of their max is. They know when they are being underloaded as much as they're being pushed too hard. So beginning with a fixed percent of 1 rep max and kind of adding or dropping weight based on feel is how they already train. Now, dialing these folks in once you've got them in the clinic and you're starting to load them is done with a concept called AMRAP sets. This is a way to double check your work. This is performing sets as prescribed, using RPE or reps in reserve during the sets to guide changes, but on the last set, performing an AMRAP set, as many reps as possible. This lets us know how close to the RPE or reps in reserve goal that we are. Mitch did a fantastic episode on the PT on Ice Daily Show, episode 529. I highly recommend you listen to this if you haven't yet to get a better idea for this concept. But AMRAP sets let us adopt a ready, fire, aim approach to loading. They let us know that we can check our work, adjust our load, and be better prepared when that patient comes in next time. Now, I would say don't be afraid of underloading somebody in the clinic because of the AMRAP set. When you do 4 sets of 8, maybe bent over rows, maybe that's the exercise we've chose for that patient. You're going to do the first 3 sets. you're going to use reps in reserve or RPE to guide that patient into the correct loading. But on that last set, you're going to say, hey, Tom, this last set, I know we said we're doing sets of 8, but I want you to do as many reps as you can here. I want you to go until you don't feel like going anymore. And now if Tom does 3 reps and our goal was an RPE of 7 or 3 reps in the reserve, boom, we know we're at the right load. We know that the next time we come in, we can maybe add 5 pounds and that we're right on the money for load. Now, if Tom does 4 reps, we know we overdosed Tom. He did not have as many reps left in the tank as we wanted him to, which means it's probably a little bit too heavy. We want him to actually get the volume in, and so we need to maybe back off the weight next time. Now, if Tom goes for 8 and rips off 37 reps, we know we underdosed Tom. So we know next time we need to get a lot heavier. We know Tom is for some reason not understanding what we're asking of him. Maybe he's not sure. Maybe he's a little bit scared of pushing himself. Whatever the reason, it's okay. But we found out using the AMRAP set that we underdosed Tom and that next time the weight needs to go up because Tom is sandbagging. And so don't be afraid to miss the mark on load because we can use an AMRAP set and better adjust our load for next time, dial it up, dial it down, whatever needs to happen. Give this episode a listen. It's worth your 15 minutes to really understand the importance of AMRAP sets, especially early on in a plan of care. Now, you're not going to do this every visit. You're not going to do an AMRAP set on all of your movements every visit. That would be probably too much volume. So we do it every couple visits. Just to make sure our loading is still dialed in. Have them choose the same exercise at the current load they're already at. Maybe they're still doing 4 sets of 8. Maybe they've moved on to 5 sets of 10 or something. Whatever the goal is, but then continue to use the AMRAP set on that last set. Beyond loading, we know that intensity matters. If you're familiar at all with CrossFit, you know the scene of the person laying on the ground or bent over, covered in sweat, maybe looking a little bit panicky. What's going on there? Why do we push ourselves to such high intensities? We know that intensity is very, very relevant, especially as it relates to injury risk, which is very important for us as physical therapists. Looking at folks here playing soccer and finding that those soccer players who could produce more than 95% of their max velocity in at least 1 training session per week had lower injury risk than those who could only produce 85% or less max velocity in 1 training session or less. Players who were able to produce over 95% of their max velocity also happen to have a higher chronic training load. And this tells us that regular engagement in high-intensity training is protective against injury, and that intensity is probably the shortcut in training to get higher gains, to develop a really robust chronic training base load, that we need to be moving at intensity. A lot of folks are very comfortable jogging at a slow, not for time pace, maybe 1 or 2 or 3 miles a week, maybe once a week or once every 10 days. A lot of folks are comfortable with that, but we can appreciate that's probably on the lower side of that MEV level as it relates to intensity. You're not going to get faster marathon times if you train that way. You're not going to get faster moving a soccer ball down the field if you train that way. We need to be reaching higher intensities and training more often, and we know that needs to happen in the clinic with patients as well, especially if they are sports players, if they are CrossFit athletes. We look at the effects of high intensity not only on performance, on injury risk, but on chronic disease. Looking at bouts of high intensity interval training versus moderate intensity continuous training, finding that the high intensity group did 10 sets of 1 minute of sprinting at 80-85% of their heart rate reserve, and then 2 minutes of recovery. And then we compared that to continuous 30 minutes at 50-55% heart rate reserve, and finding that the high intensity group had significant reductions in systolic blood pressure immediately post-exercise, 30 minutes, 60 minutes, 90 minutes, and 120 minutes. And we don't know how much longer because the study only went out 2 hours. Compare that to the moderate intensity group. Yes, they had significant changes, but only at 0 and 30 minutes post-exercise. At the hour mark, their blood pressure went back to where it was. So the evidence here for higher intensity exercise for chronic disease management and reversal. When we look at the effects of high intensity exercise, we may have the belief that it is more detrimental in our body, that because we are doing more intensity, because we are moving through greater range of motion in something like CrossFit, that it's going to break down our muscle more, and it couldn't be further from the truth. This study looking at folks training CrossFit 3 times a week for 2 months, yes, decreases in body fat, increases in VO2 max, aerobic speed, and muscular strength, but what we're looking at here mainly in the study is seeing an initial spike in inflammation in the immune system activity after the very first session of CrossFit, but then a steady decline over 2 months, seeing lower levels of creatine kinase and C-reactive protein at the end of 2 months of training. So knowing that this high-intensity training, high-intensity functional training, as we call CrossFit in the literature, is very, very beneficial not only to speed, strength, body composition, but also to our immune system, to make us less likely to get sick and to make us have lower levels overall of inflammation, which is going to help us feel less pain, feel less inflamed over time by training this modality on a regular basis. We know that intensity matters. We know that low intensity has a minimal impact on our body. This is a study from 2014 looking at the effect of running versus walking on all-cause mortality, and just finding that you need to do a ton of walking to have the same effect as running. You need to walk for almost 2 hours to have the same effect as 25 minutes of running. And we need to appreciate that no amount of walking here will ever beat running. You will not reach a point where you can walk enough and have it be equal to running. And we even see here in walking, we have a plateau effect. We actually cannot ever get the same benefit on all-cause mortality as running with walking. We have a ceiling effect here at about 35%, where running seems to cross 40% and even approach 50% reduction in all-cause mortality. So we know that intensity does indeed matter as it relates to our physical health and really our longevity. We know that we see this recommendation a lot. Maybe you give this recommendation to patients. Just walk. Hey, I need you to get more active. Just go for a walk. Now, there are some folks that walking is a stimulus for, but once they walk enough, walking no longer becomes a stimulus. We are engineered to walk. You should be able to walk many miles a day. You should be able to walk thousands and thousands and thousands of steps and not even consider it any form of exercise. And this study looked at just that, taking 2 groups, asking one group to please walk as little as possible over the next 48 weeks, and asking the exercise group to walk about 3 hours a week of exercise. What's the result? No difference in fall rates in these older adults. So walking compared to doing nothing had no effect. And again, it just shows us the benefit of low intensity is just not there. And now we get here. We get to the chronic disease epidemic that's gripping our country, that's causing the reduction in our life expectancy. And looking at this great paper from Mansager and colleagues back in 2018, and finding that elite levels of cardiorespiratory fitness were associated with up to an 80% reduction in all-cause mortality risk compared to those who had lower levels of cardiorespiratory fitness. Fantastic conclusions here. Cardiorespiratory fitness is inversely associated with long-term mortality with no observable upper limit of benefit. Basically, there's no ceiling on fitness. You cannot get in shape enough. You can always get in more shape. It will always have a benefit for you, respecting that you're not overtraining. But exercising 4, 5, 6 days a week is going to have a continual benefit on your long-term health. And basically, move more, die less. The more you can get movement in your life, not only the better you're going to feel, the less likely you are going to be injured, but the longer you're going to live, and the longer you're going to live with a higher quality of life. So how do we dose intensity in the clinic? What does that look like as we wrap up the last couple slides here? We need to organize our TheraX in a manner that promotes an elevated heart rate. We need to start to utilize rounds for time, REMOMs, AMRAPs in the clinic with our therapeutic exercise. We need to play with rest intervals. We need to play with introducing movements that maybe the person doesn't need to work on, but they're going to spike that person's heart rate. We need to start to up the intensity. Looking at all these studies that say we need to be working out closer to 70 to 80% of our heart rate reserve, and that if we're exercising at a lower intensity, it just has no benefit. So let's take the same couple movements that you may program for a patient in the clinic. Maybe this person is an athlete dealing with some low back pain, and we're a couple visits in and we've got the back pain calmed down. We want this person to do a little bit of cardio. We want them to do some Russian kettlebell swings to load up their low back and paraspinals, their hamstrings, their glutes. And maybe we want them to do box jumps or maybe some box step-ups just to get their heart rate up and load the legs. So we could program this as 3 rounds for time. We could say, hey, I want you to do 200 meters on the assault bike or the rower, or jog if you can, or even just walk. Get off that machine, finish the run or the walk, give me 10 Russian kettlebell swings, and then 5 box jumps, 3 rounds of that. If we can't jump, maybe we're doing 5 step-ups per leg. Now maybe that volume was not enough. We want to see how much volume can we get in a window of time. Maybe we want them to do an 8-minute AMRAP. Hey, I want you to get as many rounds in 8 minutes as you can of that same movement scheme. That 200-meter cardio piece, 10 Russian swings, and 5 box jumps or 5 alternating step-ups. Maybe we put it into a every minute on the minute format, or a rehabilitation every minute on the minute as we call it. Maybe we want to go for 9 minutes. Maybe here we're controlling rest for the individual to make sure that they're getting enough rest. Minute 1, I want you to do that 200-meter cardio piece. You should be done in maybe 30 to 40 seconds. The rest of the minute is your rest. Minute 2, I want you to give me 10 Russian kettlebell swings. Whenever you're done with that 10th rep, the rest of the minute is your rest. And then minute 3, I want you to give me those box jumps or box step-ups. So same movements, a couple different ways to program them to increase the intensity, get their heart rate up, get them sweating a little bit, and promote all the great changes that we see with increasing intensity of exercise, let alone increasing load over time. Now we have a great ebook up on the website, so go to ptionice.com, click the resources tab, and you can grab this REMOM ebook. We talk about this at our live course, and we take you through a practice REMOM if you've never done one. But we talk a lot about the research behind the REMOMs in this ebook. We give you a ton of examples, and this is a great resource. Even if you're already doing this, this is a great resource to give to colleagues about why do you have Diane in the corner doing kettlebell swings and rowing, and you've got a clock beeping, and what the heck are you doing back there? This is a great resource to give to that colleague. A couple different apps that are helpful. A great timer that's free on both Android and iPhone is SmartWatt. It's got an EMOM timer built in. If you're not very creative, or maybe you travel a lot, they have another app called WOD Generator, and you can tell it the equipment that you have, and it will give you a bunch of different workout ideas. So maybe you know you want somebody to deadlift or kettlebell swing or squat, but you're not sure what other movements you want to do. You tell this app the equipment that you have, and it will give you workouts based on the equipment that you have and the skills that you tell it you want to do. If apps aren't in the cards, there are analog EMOM timers from a company called Gym Boss. Same idea here. You can program work to rest intervals. You can set up EMOMs. You can set up different length intervals, maybe 3 minutes on, 1 minute off, something like that. So that's an option if Bluetooth over the speaker on your phone is not an option in the clinic. I love this quote by Andy Stumpf as we finish up here. Andy Stumpf is a Navy SEAL. He's got a podcast called Clear Hot. I've never done anything that mattered in my life in a low heart rate. We'll talk much more about this the deeper we get into the course. This is just the first week. But talking about getting people in the clinic, lifting heavy stuff, getting their heart rate up, how much fun they start to have at PT, how much your no-show cancellation rate starts to drop off, and how much fun and kind of reward you get from going in the clinic every day and starting to organize your loading in this manner, getting people lifting heavy, knowing the effects it's going to have on their muscles, their tendons, their bone, their cartilage, on their mental health as well, on top of increasing the intensity of their exercise, helping them manage or combat chronic diseases or prevent the development of one, and just become a healthier human in general that's a little bit stronger to kill is what this is all about. So in summary here, start to dose your Therex like medicine because it is, right? We talked about all the research that shows it's going to reduce symptoms. It's going to remodel tissue. It's going to help build strength. It's going to give cardiorespiratory increases, and it's going to help build a more robust human, which is much, much more effective than pills, injections, and surgery. Despite that being usual care, we need to be part of the team that is combating that. So action items walking away from week 1. If you haven't yet, film your movements, and after this, check out the case study. But when you get back in the clinic after watching this, think about, is my resistance training at 60% of the max or above? It's not always practical to test a max, especially a 1 rep max, but we can certainly test 5 rep maxes, 8 rep maxes, 12 rep maxes, and use apps like an app called literally 1 rep max to understand, hey, if I can lift 50 pounds for 12 reps, what is my actual 1 rep max? Okay, I know I need to start programming based off of that. Using RPE, using reps in reserve, using AMRAP sets to guide your exercise prescription as you go along, and then overall, just incorporating intensity to your sessions. Instead of having people go to 3x10 shoulder external rotation, 3x10 dumbbell press, and kind of going in a slow circuit in the clinic from exercise to exercise, throw all those exercises together, rounds per time, AMRAPs, remoms, really start to jack people's heart rate up, get them sweaty. You're going to be surprised how many people walk out of your clinic pain-free after a little 8-minute dose of moderate to high-intensity exercise. Fantastic way to get natural painkillers on board, to make PT fun and get those patients coming back, get them bought into PT, and oh, by the way, telling all their friends, telling their husband, telling their cousin that they had a great experience at PT, which is going to help keep your schedule full. So check out the case study if you have not. Check out the movement for this week, the front squat, and get it going if not. And then we'll see you at our very first meeting online on Monday night.